Good morning, good afternoon, good evening, our attendees from whichever corner of the world you have joined this perinatal mental health screening webinar. It is the beginning of a series of webinars which will be hosted by the Evidence and Impact Technical Working Group of the Perinatal Mental Health Community of Practice. So on this webinar, we have 441 participants who have registered. So my name is Genesis Chore, a co-host of Evidence and Impact Technical Working Group co-lead, and my other co-host is Jen Fisher. So for this webinar, we have interpretation of English to French, and to access French interpretation, click on the globe icon at the bottom of your Zoom screen and select French. Please write in the question and answer if any challenges arise within the interpretation. Today, we will be discussing the best practices and resources for screening as part of integrated, comprehensive stepped care models, and two expert guest speakers will highlight two country examples in India and South Africa. At the end, our speakers will answer questions from the audience. If you have questions, please type it in Q&A box. I am pleased to introduce my co-moderator and our two speakers. My co-moderator is Jen Fisher, co-lead of the Perinatal Mental Health Community of Practice, Evidence and Impact Technical Working Group from Monash University, Australia, but also a panelist, Dr. Prabha Chandra, Perinatal Mental Health Community of Practice co-chair, Perinatal Psychiatry Services National Institute of Mental Health and Neurosciences, India, and also our second panelist, Simone Pontman, the Perinatal Mental Health Project, University of Cape Town, South Africa. At this point in time, I would like to hand you over to my co-host, Jen Fisher. Over to you, Jen.
Thank you very much, Genesis, for introducing us all so well. If I could have the next slide, please. We want to focus most today on screening for perinatal mental health problems. And I wanted to set the scene briefly by talking about why a health system would engage in a health screening process. And we do this to identify as early as possible, either by symptoms that are already being experienced or risk factors, health problems that are not yet recognised but can be assisted through early intervention. And this requires us to have screening measures that are very sensitive to what it is we're seeking to detect and are quite specific to that condition. They need to be not burdensome to participants or informants, and they need to give findings that are readily interpreted by a health worker. And they need to carry with them clear actions to follow. The next slide, please. WHO provides us with clear recommendations for screening programs, whatever the health condition is that's being screened for. And first, there needs to be a strong case made that there's a recognised need and that the screening program has clear objectives with a clearly defined population of people with specific needs. We need to know that screening is more effective than not screening in detecting the problem and ensuring that people can be assisted early and effectively. And screening needs to be part of a more comprehensive approach of education, of service development, and of wider program management. We need to be absolutely sure that people are well informed about what they're consenting to and that their privacy is respected. It's easy for some target populations to be missed, and so good screening programs need to promote equity and access. And evaluation of the screening program should be built in from the outset. And we want always to ensure that overall the benefits outweigh the harms. The next slide, please. So what we're going to be speaking about at this webinar is screening for mental health problems experienced by women who are pregnant or who've recently given birth and are caring for newborns and infants. We know that these problems can be quite hard to recognise and that for many people, they don't have a name or a language to give to the problem that they're experiencing. So the purpose of screening for these problems is to identify who's experiencing symptoms, how many symptoms they're experiencing, how long they've experienced them, and how disabling or severe they are in terms of impact on someone's quality of life and daily activities. We know that screening alone is insufficient and that we have to have alongside it good care pathways and good services to assist in place. We know that women prefer, to the greatest extent possible, to have their psychosocial care integrated with their maternity or postpartum care, and that they experience these problems as ones that they want someone to demonstrate to them that they're interested, that they are empathic, they're sensitive to their circumstances, and overall that they are treated with great respect during this process. We know that privacy is essential, and so screening someone whose privacy cannot be assured is not ethical. We know also that screening tools have been developed in one cultural context and they cannot be assumed to perform in the same way in another. And so screening tools have to be very well culturally verified, locally validated for their sensitivity to appropriate cutoff scores to detect clinically significant problems. And what you will hear more about tonight is, do we do this in a single step or do we do a two-step process where people are asked perhaps a small set of questions and on the basis of those then assessed more comprehensively. But it's my great privilege this evening to introduce our two really internationally recognised experts in this field. They're each going to speak to you a little about their work and to talk in particular about their approaches to perinatal mental health screening. And at the end of that, we have some questions to ask them in more detail. And we really invite you, members of our audience, please to submit questions you have in the Q&A function. But first, I'd like to ask Professor Prabha Chandra, who is, as Genesis has already told us, Professor of Perinatal Psychiatry at the National Institute of Mental Health and Neurosciences in India, to talk to us about her approach to screening in India. Prabha, to you.
Thank you, Jane, and thank you, Genesis, for these introductions. And thank you, Jane, for setting the stage so beautifully and talking about why screening is important, what are the components of screening, and what are the important aspects of screening. So I'm going to talk to you a little bit today first about what are the challenges of screening in a country like India, and then talk a little bit about an experience of screening and implementing a screening program within the public health system. And then maybe I'll speculate a little upon possible recommendations, and then hand it over to Simone for her comments. So the first aspect that I would want to talk about is the challenges related to screening as we traditionally recognize it. So as you all know, the standard tools of screening which have been used in the West, which all the American group, the UK group, the Australian group recommend is the Edinburgh Postnatal Depression Scale, which we have found in many countries, particularly in the global south, to be quite challenging. And this is related to the fact that it has, the language is extremely English, British, not easily translatable. Many times our women don't really understand what it really means. The nature of scoring is very complex because each item has a different kind of scoring. So as a result, most countries in the global south and where literacy is a problem, or high volume clinics are present in the public health system, have now resorted to or discussing about shorter screening tools. For example, the patient health questionnaire or the generalized anxiety disorder questionnaire. Now, there are two types of screening. One could be the facility-based screening, and second is a community level screening. And both of these can actually differ. In a facility, there are different challenges. In a community, there are different challenges. In the facility, Jane talked about the importance of privacy and confidentiality. And many times in large facilities, you may not have that. There may be, a very high load of patients. Many midwives or nurses, doctors see 80 to 100 women a day, and it's really very hard for them to, do this thing in a systematic manner. And we've often seen that the first 10 women are screened, and after that, it's impossible to do the screening. So I think it's also about the context, which is a problem. The second thing is, again, Helen mentioned it, Jane mentioned it, and this is about, the language of mental health. In many countries, there are no words for depression or anxiety, which are so easily spoken in English. And how do you then translate, items like anxiety and depression into something that women can actually understand? So these are some of the challenges that we have faced. It's interesting that when we do research studies, many tools perform really well. And we've just had this experience in one of our research studies where we looked at a range of instruments and we got excellent sensitivity and specificity for screening. But when we actually took it and implemented it in the clinic, we found that they didn't really work very well, or in the community that they didn't work very well. Women actually did not endorse these items in the screening tools. So I think it's a interesting situation for all of us to solve, and I think it's something that we need to learn as we go on. And the important thing is about how do you implement a screening program amidst these challenges. It's very interesting that not just low and middle income countries with low literacy, where women have low literacy, are grappling. Canada, for example, recently came out with a proposal from their preventive health task force that universal screening is not really necessary in perinatal mental health. And their logic was that all primary care physicians, nurses, and health professionals should actually conversationally ask women about their mental health, and that they don't feel there's any added advantage to screening. And this came out in Canada from based on evidence. However, there's a huge uproar, and people said that's not that's not true, and screening offers great advantages. And I do believe that screening offers great advantages because, and Jane mentioned that as well, it gives you an opportunity to intervene. At least, women will talk about how they're feeling. It gives them a window of opportunity to discuss stress. So if you don't do that, then it's a problem. So I don't think that doing away with screening is the solution. I think in countries where there are very high volume clinics, where women have low literacy, where they can't do self-rating, you really need to find innovative ways of doing, asking questions about mental health. And I'm going to ask Caroline to share a couple of slides. This is just to show you some interesting and innovative ways that we've looked at, asking women about questions of risk. So screening doesn't only mean screening for depression or anxiety, but screening also means screening for risk. So for example, we encourage the midwives or the nurses to ask questions about protective factors and risk factors, and using cards like this to explain to the mother what we are actually asking. So for example, this particular card shows you, protective factors. So we tell them to ask the following questions. How well are you able to handle the common challenges that we face? Do you have people who you feel are supportive? Are you happy about this pregnancy? Are you going regularly to see your healthcare professional? Now, all these 4 factors have evidence to suggest that these are protective factors. And then the nurse or the midwife looks at, weighing like a weighing scale. So if a pregnant woman has many risk factors, apply a card which actually identifies mental health. For mild problems, offer helpful suggestions. So Caroline, can I have the next slide, which focuses on risk factors? So assessment of risk factors. So you ask them whether they've had a past history, and sometimes words like tension, which are very, which is a lay term for stress, actually elicits more response than a phrase like anxiety. Are you satisfied with the support you have? Has there been any pressure to have a male child? So again, making it very culturally nuanced. Are you worried about your financial problems? Have you had a miscarriage or a difficult pregnancy in the past? And of course, about domestic violence and fights at home. So I think cards like this, if given alongside the questions, makes the women also tend to then look at these visuals. It gives them some idea about what you're really talking about when you're saying mental health, and are able to respond. The next slide, please. And then we, go on to encouraging the health worker to ask questions which are related to the PHQ-2 or the GAD-2, about have they lost interest, have they been feeling sad or unhappy, and mind you, these are just yes and no answers. And Simone will talk to you later about the challenges of a Likert scale, though we are still trying to use it in the context of in some Indian context, but I think women might even prefer just a yes and no scale rather than using a Likert scale in cultures which are not used to questionnaires. And then you give information about supportive actions to the frontline worker. The last slide, please. So one of the things that we have asked, we have found that women find it very hard to understand mild, moderate, severe, or sometimes 2 to 3 times a week, more than 5 times a week. It's very hard for them in a short time to conceptualize some of this. So we try to use visuals, which kind of make them understand how, how severe the problem might be. And women actually seem to respond to these aids. So the point I'm trying to make is that we need to localize, we need to contextualize different screening methods, see what works. And I think that's been the experience the world over, that you need to, for you to implement something, you need to actually use many methods and see what works best in that particular context. So for example, in the state of Telangana, where we are integrating mental health into routine maternal care, and it's been pretty successful. We've trained all the health workers, we've trained the medical officers, the nurse midwives, we've got the questions, the PHQ-2 and the GAD-2 into the electronic monitoring system, into the maternal and child cards, and we are now trying to see how much it would be implemented. Looking at the uptake, we realize that only 10% of women have actually been screened. And so now it's our job to try and understand why that is so. What is it which is preventing all women from being screened? When we talk to nurses in the urban clinic, they talk about a very high patient load, which is preventing them from asking these questions. And so how do you make it easier? Because we don't want to cause stress to the health workers. We don't want them to feel burdened. And I think it's important for any screening program to be successful to try and see that the workload doesn't increase, it's minimized. And how do you gently, put it into the system so that women feel like responding? So another experience, very different. We can stop the slides. Thank you, Caroline. So another experience which is very different, which is in a slightly more high literacy private care that we are doing in Bangalore, is to have a tablet which has a self-rating tool. And we find that the uptake there is really good. We've done a feasibility and acceptability exercise, and women actually appreciated the fact that they were being asked about these questions. They liked the privacy of the fact that they could do it on their own, that they got some kind of a score and an immediate feedback about what needs to be done. So the point I'm trying to make is that it's different strokes for different folks. You might have to change the methods based on which population you're going into. To end, I would like to actually give 3 recommendations. The first, which I think Jane also emphasized, that screening should go along with education. I strongly feel that screening is an opportunity for education. So even if a woman doesn't feel like talking to the nurse the first time or the health worker the first time, at least she gets information about how mental health impacts her pregnancy or her baby. So, combining screening with education, I think, is a good strategy. And nurses have told us that women don't talk about it in their first visit, but they start talking about it in their second or third visit. And there we come to the point of how often screening needs to be done. And we probably will discuss that a little later. My second recommendation is that in high resource, high load clinics where there are lots of women coming in for help and we don't have the time, we might have to tweak our screening methods and look more at high risk women rather than screening everybody, so that at least the women who are at higher risk can be picked up. And the third is to have very clear referral pathways, because if we don't have that, then health workers get discouraged from screening. So I'm going to stop here, Jane, and I'm looking forward to listening to Simone's experience in South Africa.
Well, thank you so much, Prabha, for giving us such a rich presentation with so much expertise and the wonderful illustrative materials that you showed us. I'm sure there'll be plenty of questions for you in the Q&A section. But I'd now like to ask Dr. Simone Honigman, who leads the Perinatal Mental Health Project in Cape Town, South Africa, to talk to us about her experience there and what it is she's developed for that particular context. Simone, to you.
Hello, everybody. Thank you, Jane. Thank you, Prabha, Genesis, and the team. It's wonderful to be here. I'd like to share a little bit about the South African context, as Jane mentioned. and how we came to develop an ultra-short screening tool, which is now embedded in the maternity case record, which is the standard stationery that is used by the health system to record the entire maternity care process, and every engagement, every investigation, process of labor, birth indicators. We now have managed to embed this ultra brief tool into the maternity case record. Wanted to walk you through why we developed this tool, why did we develop a brand new tool, and also reveal some of the challenges that we're facing, some of which Prabha alluded to, and I think are global in terms of actually implementing screening, even when you have a tool that is ostensibly fit for purpose. In South Africa, we have a high prevalence of common perinatal mental disorders. We've had a good handful of prevalence studies conducted, which have showed prevalence, especially looking at the studies that have used diagnostic measures. We're looking at a prevalence of depression of between 1 in 5 and 1 in 3 women. We're looking at prevalences of anxiety that appear to be similar. And of course, there's a lot of comorbidity, and it appears that post-traumatic stress in some form is also very common in our setting. We've also conducted work that has shown that there are high levels of suicidality among pregnant women, and that that suicidality is not necessarily associated with depression. And in a substantial proportion of women, about 40%, it's not associated with depression. So when we were piloting our service project in the early 2000s, we started using the Edinburgh scale, which Prabha alluded to. It's the most widely used. In fact, there had been 2 validation studies conducted in South Africa with the EPDS. And we asked at our pilot site professional nurses and midwives, so quite highly trained health workers, to administer as often as possible this EPDS, as well as a risk factor assessment tool that we developed of common risk factors, to pregnant women attending their first antenatal visit, their first prenatal visit. We translated this EPDS into 3 languages, the common languages that were used in our setting. We changed some of the idiomatic language because we realized that, as Prabha was mentioning, some of the idioms used, like things are getting on top of me, seeing the funny side of things, were just not understood by the local population. And what we found is that it didn't work for many of the reasons Prabha alluded to. A lot of our women did not appreciate the idea of having options on a Likert scale or a multiple choice scale. We found that it took staff too long to conduct the screening, and it started imposing on their other demands, and they had a high burden of care or a high patient load to deal with. The ratios of staff to women using the services were quite low. And we found that there were several, that it was very common to have scoring inaccuracies when these professional nurses were calculating the scores on this 10-item scale. So we realized with this background, we needed to develop a tool that was fit for purpose in a real-world setting, outside of a well-controlled research setting where the validation studies had taken place. Develop something that could also detect anxiety and suicidality, be brief and binary, a yes, no, so that it could be feasibly integrated into real world settings. And we really wanted to do this well because we have within South Africa an extraordinary opportunity to to hook women into care in the antenatal period. We have a very high antenatal care uptake compared to many other African countries. And this is one of the successes of our service. We have about 97% of women having at least one antenatal visit. I mean, in some countries, only 1 in 4 women will seek facility-based care for their pregnancy care. So if women are coming to the service, we have this opportunity for prevention, detection, treatment, and as Prabha was mentioning, engaging women on mental health issues. So we developed our brief tool in 2 phases. We first conducted a psychometric validation and then moved on to cognitive testing. So the psychometric validation is the standard validation work that's done. We did an item by item assessment of 3 or 4 commonly used screening tools for depression and anxiety, and analyzed them against diagnostic gold standard. We used the mini diagnostic assessment in about just under 400 pregnant women coming from sort of fairly diverse cultural backgrounds. And we were able to generate 4 items, 2 of which coincided with the very commonly known Huli questions, which are the first two items on the PHQ. And these 4 items had good sensitivity and specificity against the diagnostic gold standards of depression and anxiety. 2 items for depression, 1 item for anxiety, and an item asking about suicidal plans and thoughts. And then we took these 4 items, and we were cautioned that we knew we needed to test this in a rigorous way, test the understanding and the cognitive validity with the women for whom the tool was intended. So we took these 4 items and all of the constructs, so we binarized some of those items that were non-binary. So we created this 4-item tool that was binary, and we took it to women in 3 different languages, who spoke 3 different languages as first languages, and we asked them in these in-depth interviews, what do you understand by the concept being bothered by? What do you understand by the concept most of the time? How do you interpret the concept in the last 2 weeks? And we were incredibly grateful for having done this work, because we realized that we made a lot of assumptions in terms of the intent of the language of the tool and how these were interpreted by the women. And we had to iteratively change the language and retest it with the women and come up with a revised set of now 3 items, because the item on lack of pleasure there wasn't a coherent appreciation of anhedonia or lack of pleasure as we health workers understand that term. Women had a completely different interpretation of that language, and it didn't work. And we found that when we removed that item, the remaining 3 items had a relatively good sensitivity and specificity against a silver standard, and we proceeded with this 3-item tool, which is now in the maternity case records that I mentioned. We have now also managed to include universal screening into the new maternity care guidelines, which are about to be published. But we've done some work to look at the fact that in truth, screening uptake is extraordinarily low by health workers in the field. And we wanted to know what this was about. It appears that, and these are the lessons we've learned from that research, when we don't train a critical mass of these frontline providers, and we don't train them with quality using competency-based capacity building strategies, it's very, very difficult for screening to happen with quality at scale. and very often one has a sort of perfunctory, automatic tick list type of screening, and the quality of that screening generates poor responses that are not valid from the women themselves. In the last 2 weeks, have you felt down, depressed, or hopeless? If one doesn't engage in an empathic and compassionate way, the how of the screening is important as the tool itself. And trainers and screeners, whoever's doing the screening, really need to appreciate that the quality of that engagement is as critical as the tool itself. And that training for that work needs to take place with role plays, repeat trainings, follow-up trainings, competency assessments. Then in terms of human resources, we need to consider how is the screening supervised? How is it monitored? Are there health indicators in the health system to monitor the screening? What are the performance indicators and the job descriptions of the people who we're asking to do the screening? And particularly, we need to mention this whole idea of opening a can of worms is a real concern for screeners. How do I manage what's going to come up? There's a real fear that if we open up and we open conversations about mental health, that it'll be too much and overwhelming. And we need to acknowledge that the screeners or the health workers themselves are very often experiencing mental health challenges, and it's extremely difficult to engage with somebody else's if we don't have the mental health of the health workers themselves addressed in some systemic form within the health system. If we don't have those resources mapped and clear pathways established, as Prabha mentioned, it is also very anxiety-provoking for screeners to start screening. So those systems issues need to be in place. So I think I'll end there and hope to have a lively discussion later. Thank you very much. Jane, I think you're on mute still.
I beg your pardon. Simone, thank you so much for such a vivid account, and you will appreciate that both our speakers are not only expert clinicians, they are researchers and evidence builders, they're advocates, they're brave implementers, and we're extraordinarily privileged to have heard from them. There are a lot of questions, and we'll do our best to get to as many as we can. The first one is, I think perhaps for you, Prabha, is it possible to understand the screening tool for a community level, or is what you presented, does that apply to both community and facility settings? So the cards that you used, could you talk to us a little bit about their use in different settings? You're mute too.
Thank you, Jane, and thank you for that question. I think it can be actually used in both settings. We originally developed it for community level, assessments or screening for really non-trained health workers when they go to women's homes. But we've and mind you, these cards were developed with the health workers and were also shown to the women themselves, and they co-created these cards. So these are very special. And we also tried to make the cards as sort of multicultural as possible within the Indian community. Different religions were represented, to make it something that women will actually identify with. So it can be used at community level. It can also be used at facility level, because I think like how Simone mentioned, that it's the how you do the screening which is more important, as important as I don't undermine the importance of the questions, but how do you do it? So if you make women recognize that these are the things that you're talking about, this is what you're focusing on their lives, you're focusing on how they're feeling, I think that will help. So these cards can actually be used both in the community and as an aid to facility or clinic-based screening as well.
Thank you.
I must
so
add here, sorry, that there's another method of community level identification which has been used in Nepal and in Pakistan, which basically and the WHO guidelines, the WHO guidance that we have a wonderful document which talks about how do you implement how do you integrate mental health into maternal systems, talks about it. And this is related to training the community in being able to identify women with mental health problems and, referring them on or talking to a health worker about it. So I think there are many ways in which we can work with communities to make it simpler and easier, enhance community awareness. So I think it's about trying to innovate and make multiple tools that can be used in the community. Sorry.
That's terrific. Simone, I think the next question really emerges from what you have already talked to us about, which is, what are your thoughts about the need to screen health workers for their own experiences of mental health problems? And do you have any examples or ideas of how these can be assisted in a workplace? Should they be assisted in a workplace?
I think we need to appreciate the mental health challenges that health workers in low resource, high burden settings are facing. Many health workers come from the same social conditions as the clients that they're serving, and face enormous challenges at work and at home. In many settings, health workers are not getting paid on time. They're getting inadequate supervision and mentoring. They have these problems at home. So I think we need to pay attention to their mental well-being if we are expecting task shifting or task sharing to work in mental health. And if we don't, I think we're going to lose the potential that task sharing provides us. I'm not sure whether the answer is to screen every single health worker. You may find in health systems that are under strain, that might just be a request too high. It might be too demanding for the health system to contain that. But I certainly think that there are a whole host of strategies that health systems should look at exploring to support, in a health promotion way, to support health worker well-being. And that would potentially relate to building team cohesion, creating a respectful environment within hierarchies that are not always respectful in the health system, reimagining how seniors or line managers could play mentoring and supervising roles, and harnessing indigenous practices for well-being that I think are dissipating over time. And in South Africa, there's an example which may be relevant in other settings. I remember when I was a medical student, every clinic or everyday hospital would start off in the morning with a collaborative music making exercise, and this was singing. We would greet and sing each other. Often there was a kind of spiritual component to the singing, and it was an extraordinary way of connecting, sometimes with the patients in the waiting room who would join in, or within a staff group, of connecting together and creating something that was beautiful and uplifting. I think there are all sorts of other creative ways that might not necessarily be costly, but I think we need to move away from a kind of disciplinary employee wellness strategy, which reacts to when a person is extremely unwell, a health worker is extremely unwell. I think there's a lot one can do in terms of health promotion, and we've found that to be quite fun and yield a lot of benefit.
What a wonderful thought to be starting our working day in that way. Barbara, I wonder if you could talk to us a little about stigma, how you understand and address stigma in your context, how stigma influences the likelihood that someone will trust the health worker and talk to them about the kinds of problems they're having, or does it just inhibit that completely?
I think stigma definitely has a role, and the words that you use are very important. So the moment you use the word mental, which is sort of considered, mental means it doesn't have a good connotation in the public view. So I think the phrases that you use, and that is why I think integration is so important, rather than coming in as a mental health professional and trying to do something at the grassroots or the community level. So having a midwife who knows you, who who can relate to you, who understands your family context, is probably the best person to discuss this with you and to discuss it in terms of stress. So we've done some qualitative studies on what are the facilitators and barriers to discussing your emotions in a clinic, in an antenatal clinic. And women have told us that they're already pretty vulnerable. They don't want to be labeled. They don't want to be sent to a psychiatrist. They don't want to be prescribed antidepressants. So these are the fears that they have, that if they say that they're depressed or upset, that it might actually be, a problem for them. And this is particularly true if there are mothers who are going through domestic violence, who are otherwise being, are very vulnerable in the society. So that's a definite challenge. But women have also told us that if you talk to us, if you ask us properly in privacy, make sure it's confidential, and we get some solution to it, we definitely want to talk about it. So there are both sides to this question, that while they don't want to be labeled, they do want to be helped and supported.
Yes.
So I think if we, as I grow older in this field, I think, framing it in the context of support and being helpful, and, making the mother realize why it's important for her to look after her mental health and well-being, rather than a disorder approach, is probably what is going to work, rather than looking at it in a very biomedical kind of a model, particularly at least in the Indian context, I think. So I think while there is stigma, no doubt, there is also, women also feel the need to be helped and supported. That it's also important for perinatal mental health services to liaise with other services. So, for example, some services which are working with gender-based violence. It's important to have that liaison, because mothers may often talk about facing violence, and then, we talked about how you don't want to open a can of worms. So then how do you support the mother? So somebody who's doing the screening or the identification or the questions should also know where to get support, not just medically or referral pathways which are vertical, but also horizontal and parallel pathways which need to be defined. So I think mothers love talking to other mothers to get support, and to have groups of mums who can get together and discuss some of these issues. So I think these are some ways in which you can actually destigmatize the whole area of mental health.
Thank you. Such helpful suggestions for us all to consider. And while you've set it in the Indian context, it is equally relevant, I can assure you, in the context in which I work, and well-resourced, privileged country like Australia. So wonderful examples. Thank you. Simone, your discussion of suicidality experienced by women in South Africa, I think, was quite shocking to everyone. And we wondered if you could talk just a little bit more about your decisions around the item on suicidality, and as it's no longer specifically included, I think from what you said, how is that addressed in the setting in which you work?
We retained the item on suicidality, but removed the item on lack of pleasure and hedonia, which we, yeah. So the item on suicidality, it's actually interesting because when we asked people the EPDS item on suicidality, the language there, I'm just going to digress a bit, but the language there was interpreted by South African women. I think, if I recall correctly, it's something about hurt yourself.
Yes.
And the language there was interpreted like getting into by South African women as being in an accident. You mean like being in a taxi accident or burning your hand on the stove? So we realized that the sort of, without using more direct language around thoughts and plans to end your life, there was a huge possibility for misinterpretation of the item. So we retained this as our third item, and we specifically placed it as a third item to build up a sort of tolerance for discussing potentially uncomfortable issues. And we were concerned that we would be swamping the system with people with suicidal thinking, given that that is potential, that is very, very prevalent and doesn't necessarily link with suicidal planning and behaviors. So we took some advice and we decided to emphasize an "and" in our screening item, so that one would, if one endorses the suicidality item, which is in the last 14 days, have you often felt like you have thoughts and, capital and in bold, plans to end your life? We thought that with both ideation and planning, that was sufficient to not have a low, sufficient to increase the sensitivity and specificity for concerning suicidality. And the scoring instructions for the administrator of the tool is that any endorsement of that item requires a referral.
Yeah.
So even if the woman does not endorse the item on depression or the item on anxiety, if she endorses that item, a direct referral needs to be made. And we luckily have a system for referral directly to an emergency room doctor, attend next to where the midwife units are based in our system. And we strengthened our relationships with the emergency room physicians in terms of fast-tracking pregnant women who endorse this item. So for the screeners, there was a confidence that they would have a quick, efficient and effective place to refer women to. And that's how we dealt with that item.
Enormously helpful. Look, we have dozens of questions. We could keep our conversation going for a great deal longer. Our time has come to a close, though. We can assure you that this is the first in a series of webinars. We hope you join us for future webinars, which will be on topics related to this, on management of the consideration of mental health in comprehensive maternity care for women. I want to thank on your behalf our wonderful panel and the most generous way in which they've shared their experiences and insights. We've had requests for slides, requests for more specific information about questions and questionnaires, And we will be putting some briefing notes about this together to distribute to our participants tonight. But I want to thank them and pass the chair back to Genesis and ask for his closing remarks.
Thank you, Jen, for your wonderful moderation. And I would also like to thank Simone and Prabha for sharing the insights and sharing their expertise. We have heard about experiences from India and also experiences from South Africa. And indeed, when you started the moderation, Jen, you indicated that mental health problems are hard to recognize and hard to name. But it is still necessary that we should be able to identify women who have or experiencing mental health problems, not alone those who are experiencing mental health problems, but those at risk too. And Simone and Prabha have shared the tools which are used for screening. And also they have shared the experiences and in some instances, the challenges which are encountered. But at most, they have agreed that we need to have tools which are culturally acceptable, which are psychometrically valid, and tools which really make sense in the local context. So screening should be contextualized. That's what we have heard. And at the same time, in the areas or settings where there is high workload or increased workload, we need to have also a well-trained critical mass of health workers. They could be midwives who could be able to do the screening. But when we are dealing with task shifting, we have to do it proper. And when we do screen, that is not the end in itself. There has to be referral pathways or pathways to care. So I would like to thank you all our participants for the questions which you have asked. They have been thought-provoking, and indeed, I should thank our panelists for answering all the questions which were forwarded to them. I know there are many other questions which have been answered now, but those questions would be answered maybe in due course. So if you are interested in joining our Global Perinatal Mental Health Community of Practice, we welcome you to sign up today. Either you enter the website or use the QR code. To use QR code, open your phone camera, point the camera at the QR code, wait for the code to scan, click the link to sign up page. My colleague Caroline will also be putting the link in the chat. So stay tuned for the date of our next webinar in our perinatal mental health measurement series. Thank you very much. And we are very excited to have you. We had more than 150 participants on this webinar, which is very much encouraging to us. Have a good day, evening, and a good night. Thank you.